كمان وجود الاستاذ الدكتور ابراهيم مصطفى. الحقيقه يعني نتعلم منه حاجات كتير وما بيتاخرش علينا، فالجلسه ان شاء الله هتبقى رائعه. الاستاذ الدكتور حلمي اباظه هيتكلم على الجاسترايتس ابديت.
شكرا دكتورة حنان for this presentation. I would like to thank you very much as well as Dr. Ibrahim Mustafa. I am going to talk about gastritis, which is a very common complaint among patients or outpatient clinics and GIT clinics. That is gastritis. Gastritis, as you know, it may be acute or may be chronic. Acute gastritis often produces no symptoms, but may cause dyspepsia, anorexia, nausea, vomiting, hematemesis, or melena. The causes of acute gastritis include aspirin, non-steroidal anti-inflammatory drugs, H. pylori by initial infection, alcohol, severe psychological stress, bile reflux following gastric surgery. Many cases resolve quickly and do not need investigations. Endoscopy and biopsy are needed to exclude peptic ulcer or cancer. The treatment of acute gastritis include treatment of underlying cause, antacids, antiemetics, acid suppression using PPIs. In chronic gastritis, it may be either due to chronic superficial HP gastritis, autoimmune gastritis, granulomatous gastritis, eosinophilic gastritis, lymphocytic gastritis, or cytomegalovirus gastritis. If we come to peptic ulcer disease, the term peptic ulcer refers to an ulcer in the lower esophagus, stomach, or duodenum. Ulcers in the stomach or duodenum may be acute or chronic. Both penetrate the muscularis mucosa. The prevalence of peptic ulcer is decreasing as a result of widespread use of H. pylori eradication therapy. Around 80% of digital ulcer patients and 70% of gastric ulcer patients are infected with H. pylori. The remaining are due to non-steroidal anti-inflammatories. If we come to H. pylori, it is a gram-negative spiral bacteria, as we all know. The bacteria produces the enzyme urease. Many different diagnostic tests for H. pylori infection are available. Some are invasive and require endoscopic examination. Others are non-invasive. They vary in sensitivity and specificity. Overall, breath tests are the best. The spread of H. pylori is facilitated by the aspects of living conditions: overcrowding, bed sharing, limited domestic services, inadequate sanitation and hygiene. Most common infection, H. pylori is the most common infection in the world, about 20%. 10% of men and 4% of women develop peptic ulcer disease. It is positive in 70–100% of peptic ulcer disease patients. H. pylori related disorders include chronic gastritis 90%, peptic ulcer disease 95–100%, gastric carcinoma, gastric lymphoma, and non-ulcer dyspepsia. So the outcome of acute HB gastritis may be chronic in cases of HB infection, may be atrophic gastritis leading to gastric ulcer and carcinoma, non-atrophic gastritis, duodenal ulcer, and mild lymphoma. Indications recommending eradication of H. pylori include peptic ulcer disease, whether active or inactive, bleeding peptic ulcer, low-grade gastric mild lymphoma, gastritis with severe abnormalities, and following early resection for gastric cancer. Management of H. pylori may be either by triple therapy of PPI, clarithromycin, or amoxicillin, and metronidazole for 7 days. H. pylori eradication success is achieved in 90% of the patients. Patients who remain infected, the choice is quadruple therapy, bismuth, PPI, and 2 antibiotics on long-term or maintenance therapy with acid suppression. Standard triple therapy may include PPI and amoxicillin and clarithromycin for 7 to 14 days, or PPI second. Standard triple therapy also includes PPI, metronidazole, and clarithromycin. Levofloxacin-based therapy include PPI, amoxicillin, levofloxacin for 10 to 14 days. Causes of failure may be attributed to antibiotic resistance, lack of patient compliance, inadequate education regimen, smoking, and geographical area. Now we come to non-steroidal anti-inflammatory drugs. About 30 million people worldwide take non-steroidals on a daily basis. 40% of them are older than 60 years. Non-steroidal gastrointestinal adverse effects range from dyspepsia and peptic ulcer disease to more serious complications as hemorrhage and perforation. Small bowel and colonic complications are also reported as perforation, bleeding, and stricture. 40% of long-term users of non-steroidals can develop asymptomatic duodenal ulcer. About 4% may develop complications as perforation or bleeding. Patients at increased risk include patients with history of peptic ulcer or hemorrhage, elderly patients, prolonged use of non-steroidal, concomitant use of corticosteroids and or anticoagulant, systemic illness as renal, cardiovascular, hepatic, or uncontrolled diabetes. H. pylori infection and non-steroidal use are independent additive risk factors for the development of gastrointestinal ulcers. Symptomatology of peptic ulcer disease include recurrent abdominal pain localized to the epigastrium related to food and occurs in episodes, vomiting in 40% of the patients, persistent vomiting suggests gastric outlet obstruction. History of treatment with non-steroidal is sometimes present, especially in elderly. Anorexia and nausea, silent ulcer presents with anemia from chronic undetected blood loss and hematemesis. Investigations include endoscopy, biopsy if malignant ulcer is suspected. Complications of peptic ulcer disease include perforation, gastric outlet obstruction, and bleeding. The management include esomeprazole. All the types of PPIs are effective, well-tolerated agents that protect the stomach and the duodenum during non-steroidal administration. Refractory peptic ulcer disease, we may have gastric ulcer refractory, that does not heal after 12 weeks of H2 receptor antagonist therapy or 8 weeks of PPI therapy. And refractory duodenal ulcer is ulcers that do not heal after 8 weeks of full dose H2 receptor antagonist or after 6 weeks of PPI therapy. Refractoriness of peptic ulcer may be either due to persistent HB infection or non-steroidal related ulcers, impaired healing, inadequate inhibition of acid secretion, or hypersecretory states, Zollinger-Ellison syndrome. Also, comorbidity, chronic renal failure, respiratory failure, cirrhosis, and immunosuppressants. Diagnostic approach include careful clinical evaluation, endoscopy, and biopsy for H. pylori, for chronic active gastritis and malignancy. Management include eradication of the H. pylori, discontinuation of non-steroidal anti-inflammatory drugs, potent anti-secretory therapy, shifting from H2 receptor antagonist to 2 PPI, and surgery later on. Acute GIT bleeding, which sometimes occurs in these patients, 80% to 90% of upper GIT non-variceal bleeding cases are due to gastric ulcers. An increasing portion are due to the use of aspirin and non-steroidals, predominantly occurring among elderly, and the mortality rate is high from 5% to 10%. Management of acute bleeding from peptic ulcer. Assessment, resuscitation, and the correction of hemodynamic state. Initiation with intravenous esomeprazole, bolus, plus continuous infusion. No role for H2 blockers. No role for sandostatin or octreotide. Early endoscopy and second look endoscopy is essential. This is a trial which has been done on esomeprazole, a randomized double-blind parallel group placebo-controlled study of esomeprazole intravenously administered for 72 hours to assess the prevention of rebleeding in subjects that have undergone successful primary endoscopic hemostasis for a bleeding peptic ulcer. The results shows that esomeprazole given as an intravenous infusion followed by esomeprazole oral after successful endoscopic hemostasis was highly effective and well tolerated. Thank you very much.
الحقيقة أشكر الدكتور حلمي على حاجتين، على التقديم العلمي الممتاز وعلى إن هو كرئيس مؤتمر قدر يراعي الوقت الحقيقة يعني، فهو يعني بيعلم الناس الالتزام يعني. طبعا ده احنا زي ما اتفقنا ده سيمبوزيوم أسترا، وراه في سيمبوزيوم بفاركو، وراه في سيمبوزيوم بتاكيدا، فهنخلي كل سيمبوزيوم الحقيقة الأسئلة فيه بعدين. فأي سؤال للدكتور حلمي؟